I'd like to get started by introducing one of our speakers who's going to discuss how communities across the country are leveraging community paramedicine and mobile integrated health for better patient care. Chris Call is a familiar name in EMS. He's a co-founder of EMS One and founder of Paramedic.com. Chris got his career start as a firefighter and EMT. He's worked as a firefighter captain, paramedic, and ambulance service director. Most recently, he practiced as a critical care flight paramedic, covering Southwest rural Montana and Yellowstone National Park. With over 26 years of experience, Chris serves as the Chief Marketing Officer of Pulsara, a healthcare and EMS tech startup. Welcome, Chris, and now I'm going to turn the webinar over to you so we can get started with today's presentation.
Great, thank you. This is really exciting for me. When we talk about community paramedicine, everybody has a different idea of what community paramedicine is. And that's not unreasonable. It's not unreasonable because what your needs in your community may be different than the needs of my community. And that's really what the community paramedicine focus is. Today we're going to talk about that and how to implement and start looking at ways that the world can be changed because of community paramedics and this expanded scope of practice. Really, to its core, and by definition, community paramedicine allows paramedics to function outside of their traditional emergency responses, where we always went to the patient. We may have treated them, but most often we transported them to a hospital. Now that hospital may or may not be the correct place. As we walk through this, you're going to learn different steps and unique wins around the country that have helped shape and make our health system greater and more robust because of an expanded scope of medicine. As paramedics, we look at it as this is what we've always done, and we're in that dynamic of change where how EMS and how paramedicine may have looked in the 70s, 80s, 90s will look vastly different in the future. One of our challenges as we move into community paramedicine is being able to connect the right people with the right resources at the right time. And communication will be a super difficult hurdle for us to overcome. As I look at it, and of course, my background in communications and working with Pulsara is that we need a way for us to, at the time of an incident, make sure that we can connect with the right provider. That could be mental health. It could be a family practice physician. It could be telemedicine. It could be a number of different areas so that we can grasp the right information at the right time for the right patient so we can treat them appropriately and, if needed, transport them appropriately. As you look at this graph or in this image, you can see there's a lot of arrows in there. And really, if you look at the yellow ambulances in the circle and you look over to the emergency room, that's what we've done in the past. And when we look at those and we think through how do we connect there, it's been historically through a cell phone or through a handheld radio. But now our focus is more along that of the hospital. And when you look at on the side of the white side where you're looking at all the different practitioners needing to get different information from different clinicians at different times, it becomes a tangled web. In our new focus of EMS, we're going to start working in that area. One of the things I want to caution us on is change management. How do we make sure that we are making the right decisions at the right time? It's one thing for us to talk about what we could do as community paramedics. It's another thing for us to talk about how would the world work best if it was through my lens or your lens. It's different to actually put that change into practice and actually have different outcomes. We love this graph. When I'm looking at this, what it says is managing complex change is a challenge and it's difficult at best. And really there's 5 different things that you need to do when managing change. You need to have the vision. You need to provide people with the skills necessary to do their job. You need to incentivize them. Why are they doing this? Is this something just added extra to their job, or is there a reason behind it? You need to provide them all the resources in order to equip them to do that job. And then you need an action plan. Turns out, if you're missing any one of those 5 steps, the end result is not change management. In fact, if you're missing vision, for example, you'll see that people will be confused. And I'm sure that many of you have had this happen in the past. If you have vision and the incentives and the resources, but you haven't provided your medics the training and skills, there's anxiety. If you don't share with people the why that you're doing it, they'll be resistant to that change. If you share the why, they're excited, you have the skills, the action plan, but they don't have the resources, you'll see frustration. And the worst is if you get all the way to the end, but you don't have a plan. And today, that's what we're going to be talking about, a plan, so you don't have a false start when it comes to community paramedicine. As we walk through this today, there's a lot of buzzwords out there. Community paramedicine, mobile integrated health, EP3, and there's been a lot of buzz around these concepts in the EMS community. But what does it actually look like when a community implements a paramedic program, a community paramedicine program? And what are the specific patient care and communication benefits that those sites have seen? Today, we're going to walk through these next 3 objectives. We're going to talk about implementing a community paramedicine program in your community. We're going to talk about leveraging the benefits of launching a community paramedicine program from the wins of others. And we're going to talk about overcoming some of the barriers when starting a paramedic program. With me is Ann Montera. Ann has spent the past 25 years as a nurse in public health, labor and delivery, working with patient safety and quality improvement, and then as an EMS coordinator in both urban and rural hospitals and the community settings. And recently completed her master's degree in health leadership from Western Governors University. And her years in EMS experience in health leadership led her to become the executive director for the Central Mountains RETAC, supporting a 6-county EMS and Trauma region in Colorado. And is also currently serving her 2nd term on the National Advisory Council as a vice chair and representing the public health sector. My friend Ann has a strong passion for changing our healthcare system. As a patient, she's experienced the dysfunction firsthand. Knowing that a large percentage of medical errors involve bad communication, Ann has become a change agent to improve the current and fragmented system of care. Most importantly, she's a rad friend of mine and a colleague that I've been blessed to know over the past decade. And incidentally, as we are talking about community paramedicine, it's a fun fact that Ann is the co-creator and public health partner for the first national community paramedic pilot program in rural Eagle, Colorado. Ann, welcome.
Thank you so much, Chris, for having me. I really appreciate it. There's also another side note that I'm also working with Pulsara as the client service specialist, but I come to you today as a community paramedic veteran, if you could say, into some sort, and share some of my knowledge and expertise going through this journey over the last 10 years. And I just really appreciate EMS1 and Pulsara for giving me this opportunity to share this. I've done tons of presentations, and I think this one is near and dear to my heart because I'm going to start with a case study of someone that I know personally and to kind of share through this journey. I would love for you to meet Chance. Chance is, his name is Chance because there was no way on this earth that he would have ever even made it to even being born. He had so many complications in preterm. When his mother was pregnant, but he did make it and he is alive and well on this earth. But I want to tell you a little bit about Chance. He was a mover and a shaker. He had an older brother, loving life. But when he turned 2.5 years old, he had his very first seizure. From that point, the seizures started coming over and over and over again. At one point, he had 180 seizures per day on average. Imagine that. As providers, when we just handle a patient with 1 seizure, could you imagine being a parent and taking care of your 2-year-old having over 180 seizures a day? He was diagnosed with every type of epilepsy, and he needed to be continuously monitored. He was taken to Children's Hospital in Colorado, the Mayo Clinic in Minnesota, and just was constantly getting tests done and trying to figure out and get to the source of the problem. Enter into the school system. He did make it till he was 5, and he was able to make it to where he could go to school for the very first time. But going into a school system in Eagle County, a population of 50,000, There was only one registered nurse for 28 schools. Could you imagine a little boy having multiple seizures, up to maybe 100 a day during the school? On some days, how could this one nurse or the system handle and take care of Chance? 911 was called on a weekly basis to come in and transport him, not having the resources to know what to do or how to manage it. This is just painting a slight picture of now we're going to go into the different other parts of how a community can come around a patient such as this and really understanding why is there a need in our community. When looking at that, I want us to think about this changing landscape of our healthcare system. Healthcare reimbursement is changing. Our healthcare system from day to day, we don't know what's going to be reimbursed, what medication is going to cost an arm and a leg, if those emergency medicine medications that Chance was needing just to survive, will his parents be able to afford it? Maybe 10 years ago, an EpiPen of some sort would have cost $100, but now it could cost $3,000. How do we know what's going to be the next barrier to our healthcare? We need to look to all these different creative ways to deliver care. We need to look within our community at the needs, and we also need to look around to different resources and help each other out as care providers. There is a growing need for more nurses and care providers, but as we're seeing across the country, there's an aging population where nurses are retiring. We only have 1 in 3 public health providers that are available to meet all the public health needs that we have. And we have job lists after job lists for EMTs and paramedics still going unfilled. So this broken system, patients are getting missed, and we really need to find a way to deliver the appropriate care at the appropriate time with the appropriate resources. This is that complex challenge that we all are faced with. So in this crazy world that we're living in, all these different medical needs sometimes can be missed completely, they can be misappropriated, or they could lack resources or getting the wrong resources. This provides a lot of problems. The overcrowding of EDs, the overutilization of 911, the underutilization of other resources. So what can we do as a whole system, as patients of the healthcare system, as providers in the system, to look creatively outside of all of what's going on to fit this need? So I'm going to start with just taking you through an example of a patient demand on the healthcare system. I want each of you to envision 1,000 people. So that 1,000 people could be in your community, in the size of your high school. It could be your entire county size. But I want you to think of that 1,000 people. And in one day, 250 of them will have some sort of something that goes wrong with their health. They could have a headache. They could have a heart attack. They could break a leg. Of those 250 people, only 75 of them are going to be able to handle that without any medical care. Of those, 75 of them are going to be able to care for it on their own. Now, 25 are going to need some sort of primary care that they need to access during that day. Of the 25, 3 will need some sort of specialty care, and 1 will need to be hospitalized. So just think of that 1,000 people and the resources that maybe the 1,000 people will have access to. So I want to kind of change this up just a tad and kind of put it into a different population for you to think about. So I'm going to, what I call is Eagle County-ize the population. Like I said before, we have a population of 50,000. So this is something, again, you'll have access to these resources later for you to then work these numbers in your own area. But in our 50,000 population, we are located up in the heart of the Rocky Mountains with ski resorts of Vail and Beaver Creek, 1 critical access hospital, and the 2nd busiest airport in the state. Up here in each day, we'll have over 12,000 people that are going to have some sort of health need that goes on. Of the 12,000, a little under 4,000 are going to be able to not need too much of that care to be able to need to access it. They're going to be able to care for that on their own. But 1,200 are going to need to access our primary care. Now, when we started our community paramedic program here in Eagle County almost 10 years ago, at that time, and we identified such a need and a gap, there was only 4 primary care practices in the county and only 1 accepted Medicare and Medicaid. So if at that time we had a 26% uninsured rate, how would 26% of the 1,200 that needed to access primary care actually get seen? Then we went into this idea of the specialty care and also looking into rural areas and accessing rural needs. And 150 of those people are going to need to have some sort of specialty care. Well, if you're up here and you break a leg skiing, we've got the specialist, but we lack in cardiology and neurology and other specialists. A neurologist that maybe Chance might need someday. And then of those 150, 50 would need to be hospitalized. And I misspoke, it wasn't a critical access hospital that we have, but we have a 58-bed hospital. So in one day, if we don't have the appropriate resources and needs to care for all these patients, how will them, all the way down to 50 people to be hospitalized a day, be able to be cared for? In our normal, traditional setting of the 4 walls of the hospital, I think that we need to start looking into the next area of outside those 4 walls and breaking down silos to meet these needs. So one thing that I like to kind of clear up and just make sure that we're all on the same page is talking about some nomenclature. There's a lot going on about understanding what is a paramedic, what are we called in the industry, what are nurses called, what is this ET3 thing, what are we thinking and talking about when we talk about what's the difference between a community paramedic in Colorado or a community EMT in Minnesota. So I just wanted to be able to define some of that for you. I'm going to first start by coming through and defining the difference between us in the United States and the difference internationally. So internationally, the term of paramedic, the EMS chiefs from around the world have come together to really rally around this nomenclature of the single term of paramedic, but putting the primary care paramedic, intermediate, advanced, critical care community, and then ultimately calling the service a paramedic service. Where here in the United States, we have an identity crisis, looking at what are we an EMT, advanced EMT, paramedic. When looking across states, community paramedics are called all different things in every different states, and looking at us as an ambulance service. So knowing all of that, I wanted to define some of that for you. I see a community paramedic is the provider of care, providing community paramedicine in their community. There are states, again, like I said before, that are community health paramedics, community EMTs, or community EMS providers. Those are all licensed or certified providers that work under the current scope of practice within their states and within their communities, serving those community needs. They can work independently or within their care team as their state has set that out in rules and regulations. Next, I want to look at mobile integrated care, healthcare. Mobile integration I see as a team of providers working together to care for patients in that at-a-hospital setting. It could be working with a nurse call center. It could be a co-response model with a paramedic, a traditional paramedic, and a nurse practitioner responding to the home. And it's just that mobile team. A lot of states are also embracing this integrated care model of an integrated practice. The practice isn't always mobile. So having that coordination of that care with those different care team members is also a different way to look at that. I do see that a community paramedic could be a part of that integrated care team or that mobile integrated health team. Lastly, I want us to look and define what this ET3 thing is. That's what I hear it said. You know, that ET3 thing, that's kind of community paramedic, but it's really not. But what is that all about? It's the emergency triage, treat, and transport that allows, that the federal government has put forth through the Center for Medicare and Medicaid Innovation Center to be able to find a way for us to care for these patients and get reimbursed in a more creative manner. They're in the process of evaluating those applications that they received, but really the three main concepts of the ET3 is they want to transport, it's the three, to be able to transport to an ED or destination covered under current regulation, and all these items you would be reimbursed for. Second, transport to an alternative destination. And third, provide treatment in place where appropriate with an appropriate provider as designated a provider within your current state and practice, or through telehealth, or both. Again, really looking back at improving the quality and lowering the cost by reducing the avoidable transports to the emergency department and unnecessary hospitalizations. One last thing that I kind of want to add into that in looking at this is, as an industry, I think we need to look at who are we and how do we identify ourselves. Often in the community, when you see an ambulance going down the road, you ask the community who is driving that or who is in the four walls of that truck. And you will hear EMT, paramedic, or ambulance driver. Something I just want an example that someone gave me. When you see a red truck with lights and sirens on it, that's large with ladders on it, when you are asked who drives that, do you ever hear them say, that's a fire truck driver? Or if you see a car with lights and sirens, do you ever hear them say, that's a police car driver? So as we advance not only this idea of who we are as EMS, paramedics, community paramedics, etc., I think we need to look at how the outside is identifying us with this identity crisis that we have. So going on, I want us to go into just the different standards, such as the education and certification of what it takes to be a community paramedic. I think first, as we are going out into the community and interested in educating or starting a community paramedic program, the first thing you need to do is educate the community first about what is a paramedic, what is EMS. Again, they see us primarily as ambulance drivers. So what can we do to change that? It is sitting down and explaining to them that paramedics and EMTs come to the table with education and training to provide high-level care currently in an emergent setting. But now with this idea of a community paramedic, we can also do so much more. And so being able to educate them and the community about paramedicine and community paramedicine would be the first thing that we would ask for you to do. The second thing is to be able to educate the provider of care. You need to find that education institution and the subject matter experts to host this type of education that is different than your traditional paramedic education. And your normal paramedic training centers and your paramedic education and paramedic instructors, this is going to be a little different. So through the years, we've developed a national curriculum, and we've worked with certification and done studies to be able to advance the education. The courses that we're seeing, we have 3 different levels of courses that are out there. We have what we call the technician level, which is to educate providers on alternative destinations. We have the clinician level that allows the providers to work independently within their current scope of practice. And then in the future, we have some universities that are looking to have a community paramedic practitioner with a master's degree. So talking just typically about the clinician level, it's around 100 to 300 hours of clinical and didactic time. And upon completion, they can sit for a board certification. The International Board of Specialty certification, the ones that have created the critical care paramedic, the flight paramedic, tactical paramedics, has also created the community paramedic certification. A lot of our states that we've seen that are adopting this form of requirement are requiring the providers to take that college level clinical course and then pass the certification exam to be an accepted provider within the system and to be able to be reimbursed in the future. So now we have the need of what is in our community. We have the educated provider, but there's a couple of other little nuances to this. I think we need to understand the importance that this is an expanded role of the provider, not ultimately the expanded scope. Now, through legislation, some changes. Have there been some expanded scopes? Yes, but really what we're doing is taking the paramedic in their current practice, giving them additional education, focusing those areas on the community needs, and filling those gaps and working alongside other healthcare providers. So when I look about that, when I think about that, and I think about a community paramedic, they're in the areas of primary care, still in emergency care. They're working within along public health, disease management, prevention, wellness. We're seeing a big uptake in the mental health arena and even in oral health. So what are the steps and the things that you need to do going forward? What do you need to know? The first thing is you need to plan. You need to plan and create a work plan. A friend of mine said, like airway medicine, do you need to plan to ahead of time to ensure that that patient's going to be okay to establish an airway? Are you going to plan out all of your tools, all of your training and everything that you need? Of course you're going to. So let's do the same thing when planning out for a community paramedic. There's other things that you need to do to see if it's feasible, like adopting current legislation, working with your state EMS office to see what requirements are in place at this point. Can you even have practice as a community paramedic in the state? And working with those internal commitments within your own organization as well. There's could be a lot of pushback and people not wanting to be a part of this new change, but understanding and planning ahead of time and creating that work plan will help you through that whole process to lead through that culture change and communicate the progress of the program and ultimately lead to success. And then lastly, plan to connect with that college or university to establish that education. We currently have 16 states that have either enabled legislation and or have rules or regs in place for CP providers and services. There's one state and one group that I want to bring some attention to. In Pittsburgh, Dan Swayze is an associate VP working with a health plan in Pittsburgh with UPMC as a health plan. What they have done is they are able, because of the health plan has access to all of the patient's healthcare records, they are identifying where the needs are at the highest level. They're able to see every provider the patients see, every test that is done. So they've brought in this community paramedic concept to fill those identified needs and be able to help monitor and progress these patients through an appropriate path to wellness and decreasing illness, and ultimately setting up that population and this program to fill all those gaps. The next step that you need to do is you need to assess your community's needs. You need to find those right stakeholders, whether that's through different community needs assessments. I would recommend that you're working with your public health department. They do community assessments. Your nonprofit hospitals are required to do health assessments. A lot of all those stakeholders come together, look at the data, look at the needs in the community. We already have enough silos of the 4 walls around the hospital or the 4 walls around our ambulance. We need to break down all those silos, really look at the data of what the needs are and bring everyone together to say, what can we do to improve the outcome and fill these gaps and meet the needs in our community? An example where this has been done is in the city of San Diego. I want you to meet Ann Jensen. She's a resource manager that has been working as a community paramedic and leading the program as they identified that they had gaps for mental health services in the city. The program, before the program, the amount of patients going to the ED or calling 911 or disrupting the system as a whole, all just for mental health, because they're lacking mental health patients, was such a need that they looked to the city of San Diego to handle this. So because of that, this program has decreased ED utilization. They are now expanding this to other resources and other areas beyond San Diego, but the needs were identified in their community, and the community paramedics came in to fill those gaps, and it's been such a success. So the next thing that you need to do, so you've planned, you have assessed the needs, and now you need to begin operations and get things done. How in the heck are you going to put this all together? Well, there's lots of resources out there for you, but here are a couple of things I think that you need to consider. You need to look at your medical direction. You need to look at community paramedic programs the same as you look at your 911 program or your critical care program. The medical direction is very crucial. Now, it may not be your 911 medical director. It could be an advisor in and out of primary care, public health, and different realms within your community that have more expertise of chronic disease management and public health and prevention. But that medical director's role is really crucial. It's crucial in leading through so many different areas of continuous quality improvement, et cetera. You also need to evaluate your documentation system. Looking at our traditional 911 EPCR systems that document per incident and not per patient medical record, there is a disconnect. And so working with your hospitals, your local medical practices, what could you do to help get that communication and those documentations streamlined so you can talk back and forth with your local providers? So when I look and I think about communication, I think back to the reason why that I am working with Pulsara, and there is such a disconnect in silos of communication, and this chance to be able in this role as a community paramedic to work across all spectrums of the healthcare system and connecting them and communicating. So looking for tools and resources for you to be able to connect the patient's care across all spectrums of care is really important. Telemedicine is another great way to be able to do that, and in the field and connecting back to resources that you may not have or that patients can't access out of their home. Lastly, the last couple of things to think about is how are you going to schedule these patients? How are you going to accept referrals? And then what system are you going to do to close that loop and follow up on visit after visit, if you need to go back to do other community paramedic visits, or if you need to link them to other resources in your community. So with that, I want to introduce you to a friend of mine, Dr. Mike Wilcox. He has been crucially involved as the medical director with North Memorial in Minnesota. He has been their biggest champion. He is also, I would say, the grandfather of medical directors across the nation in helping evolve the education, helping evolve documentation and competency, but also he is there and helps them through the CQI process, ensuring that they know that what they're doing is the right thing. Are they missing things in this new realm of out of their comfort zone? Are they ensuring appropriate follow-up? And because of his oversight, this expansion of what North Memorial has been able to do with their community paramedics is allowed this to be the largest health system to be impacted by one of the largest community paramedic programs in the nation. And they're a great model to show how they put together the education, the planning, and ultimately that medical direction to be successful. So as we move on, you need to continually go back, reevaluate how you're doing. You need to evolve. Things are going to be ever changing. At the very beginning, You could say, oh, I think I'm just going to do a CHF program, and we're only going to need to learn about how we're going to need to take care of CHF patients, and we're going to only link with the services with that. But as your community gets a taste of the success and the untapped resources for your CHF program, I guarantee you they're going to want you to do so much more. So continuously going back and to see what can we do to improve, to make this better, to grow and evaluate and always see where you can improve. One great way to do this is to create an advisory group. On a quarterly basis, bring together the stakeholders that you've engaged. Allow them to give you feedback. Figure out where you're missing the ball, what can you improve upon, but then celebrate on these huge successes of these huge success stories that we're hearing all over the country. It also is a way for you to collect the data and report back to the advisory group those successes. Collecting the data is not always the easiest thing to do, but it's very important. I've always said, from patient number one, you need to collect the impact that you're having on that healthcare system, the impact you're having on patients, the things you're preventing, what are you improving? And we're going to talk about that data collection in more detail in just a bit. Sometimes it's also hard and you have to ask the tough questions. You need to stop and say, so are things working? Are they working well? What's not working? It's not always what you want to do, but it's something that is very important to the change process, change management, and the continuous need to improve outcomes. One thing that some examples of what some states are doing is they're going back, they've established some pilot programs, and they're having people come back in and reevaluate how these pilots are doing, and then setting out what the standards will be for implementation of new programs in the future. I really commend states like Idaho and California that are in the process of doing that or have done that. And in the end, they come out with things such as a community paramedic toolkit to guide people through those processes, so to lead them up to be successful in the future. So one other group that I want to talk to you about is a group that has continuously gone back and evolved and talked about what could they do to improve things throughout the community. I'm going to introduce you to Eagle County Paramedics. And as Chris introduced you this at the beginning, this is the group that I helped start up as a public health partner, the first rural community paramedic program in the nation. And when that program started, we knew that we wanted to do anything and everything to meet these needs based on our needs assessment, but it has continuously evolved. At one point, when the district realized that we had one of the highest suicide rates in the nation, and we lacked in crisis services and resources, they worked to bring partners in from other counties and worked with other people throughout the state to set up a 24/7 co-crisis response model in a place where there was very limited mental health resources. That program continues to evolve. They have decreased the ED visitation. They've even seen a decrease in the suicide rate. But to be able to continuously go back and say, what can we do to improve? What can we do to change things? We may have to change a model that was never even anticipated from the very beginning, but because of that, they are saving lives. So as we are continuing to look at these different programs, what do we do next? What should you do next? My public health hat on, in the evaluation piece, like I said, measuring your outcomes is so crucial. So there's been a group, and through also with some of the work with this ET3 model, you're going to see where there are this development of national performance measures. So developing measures at your local level of impact, but then also contributing to the national measures is very important. This is how you're going to show value, impact, how you're going to work towards reimbursement in the future. You're going to get payers to then reimburse you. If you don't have that data, how are they going to know how to pay you for all the exceptional work you're doing? So I'm going to quickly go through some of these different elements of the national performance measures. So they're outcome measures, and they're based on outcomes and then the interventions. So the first set is our quality measures. It is they look at how the change of primary care utilization are now these patients that weren't linked to primary care now accessing primary care instead of the ED. We are seeing that in over 50% of the cases that medication inventory and reconciliation is necessary and important. And so how often are you being impactful with helping that with your patients? Are you able to decrease the unplanned acute care utilization in the ED or calling 911? And are you minimizing those adverse outcomes? The evaluation national measures that we're looking at is patient satisfaction and the patient's quality of life. How are the patients perceiving themselves at the beginning of time with community paramedic to how they perceive their lives with the resources and tools and education they now have to be self-sufficient? How, and looking at the rest of the healthcare spectrum and measuring and being reimbursed based on patient satisfaction, this is a way also to start evaluating those quality measures and outcomes. Then looking at utilization, how is the impact of the community paramedic impacting your ambulance transports? If you happen to have a subset of a population that was utilizing your ambulance transports for their ride to the ED, for what their ED they called as primary care, is that now being decreased? In the future, like looking with ET3, is that unnecessary transport for 911, maybe that won't be reimbursed in the future. So what do we need to do now to measure that? And this is one way to look at that. Looking at how you can help keep these patients out of the hospitals 90 days after they've been discharged, or even not having them not go to the hospital for 90 days and taking care of them. And then after they've been admitted to the hospital, making sure they don't go back within the 30, 60, 90 days going forward. The next one is the cost savings. If you're able to provide a community paramedic visit or impact of those resources, the education, linking them to where they need to be, what can you do to save healthcare savings? So looking nationally, we're looking at hospital ED visit savings within that 90-day period, and all causes of hospital admission savings. What can we do to decrease all hospital admissions? And then looking at the emergency department capacity. Going to the emergency department, but then the last measure is the bed consumption and the capacity, especially with our mental health population and how they are waiting for other beds that are, and the resources outside of the ED. What can we do to show the impact of opening up those beds for the patients that really do need the care? And this, to me, really is kind of the future of some of the measures, not only for this, but also as ET3 evolves and we see that grow. So with all of that information, I want to take you back to something. I want you to also remember that need in that process change that Chris talked about in that initial slide, and all those needs for successful change. Change is not easy at all, but it's necessary, and we know that it can save lives. So let's go back to Chance, my little buddy Chance. Do you know that what happened after 911 was called so many times to the schools to take care of Chance? They called the community paramedic Kevin in to say, Kevin, we've got to help out with Chance. We only have one nurse for our 28 schools. What can we do to help Chance out? So they put a specialized plan in place for Chance, educating the teachers, giving them the resources they needed to be able to handle Chance, giving them training to be able to administer the medication that would decrease the chance of his seizures. They would review and put this in place at the beginning of the school year, at every break. Any chance that, anytime that more seizures were coming or there was a new change in the treatment plan, the community paramedic would go out yet again and work with the school team, with Chance and his mom, in order to make sure that he could successfully function into the system. He now has become very active in his school. They have changed all school district policies, and every child with any healthcare need now gets the special plan in place, their care plan per se. And because of this, Chance is functioning and just doing fantastic. He has gone to the point of getting and finding other innovative treatments. He has hiccups every now and then, but now they have a plan to take care of him. And he's no longer having those 180 seizures a day. But if the community hadn't come around, identified that need, if a community paramedic hadn't been so patient to say, what can we do to help Chance out? I don't know where Chance would be today. To summarize, I think as you're looking at this, this is Community Paramedicine 101. But if there's 4 takeaways, these are the things that I'd really like for you to take away with. 1, I want you to engage those partners and your stakeholders. You cannot buy enough lunches or go back to them and get that feedback from them and that buy-in. Complete that community assessment or look at the assessing those needs and making sure you're not duplicating things, breaking down those silos. Commit to that process. Put together a work plan. Have those steps. Make sure that you're hitting your timelines. You're checking things off. Do not take shortcuts. And then evaluate your whole progress. What can you do to improve what you're doing every step of the way, whether your program is up and going for 6 months, 6 years, or 10 years. So with that being said, I do know that we will be able to provide for you. We have this 12-step process for developing your community paramedic program. This is a handout that we're going to be providing for you guys after this webinar. But with that being said, I think we're going to open this up for questions and see what we can do in the last couple of minutes just to help you guys through this next phase of changing the healthcare system.
Thank you so much, Anne, for that great presentation, and Chris, to you as well. So it looks like we have a couple of questions regarding whether this presentation is going to be available later today. The answer to everyone who's been wondering that is the answer is yes. We will be sending along a recording of this webinar, but let me address some questions that we have from the crowd. Chris or Anne, you can both take these questions. I'll leave it up to you both. The first question we have is, how are community paramedicine programs subsidized?
I can take that one. Currently, we're seeing them subsidized in various different ways. We are seeing them initially to be grant funded, but more and more every day, we're seeing that once there is the established provider within the healthcare system of a community paramedic, and that is usually done through changing through legislation or through rules or regulations, then that provider can be reimbursed. Right now, a lot of the programs are going to their payers at the state level and local level to say, we can provide X service, and then negotiating what that reimbursement would be. So they are being reimbursed by private and public payers at the state level. Now that's evolving. That's different state to state. But I think that's part of this push with ET3 is to have the insurance companies start thinking about different ways for the programs to be reimbursed.
Gotcha, and thank you so much for that answer. And, you know, in your experience, Anne, how long do you think it takes for communities to really latch on to the community paramedicine model? Do you find that patients and EMS staff easily adopt to this, or would you say that there's a big learning curve involved?
I would say definitely there is a learning curve. In a community, let's start at the community level. I think some of the healthcare providers aren't familiar or haven't worked alongside paramedics on a regular basis. They're used to the paramedics just bringing the patients to the ED and then not following up afterwards. So to get that buy-in and that support is really crucial, and that's why that engagement piece is so important. it can sometimes take you 5, 10, 20, 50 times going to a practice or meeting with a provider for them to finally get it, how impactful the community paramedic can be if they work together with them. Now, there can be some practices or some physicians that get it right away, but it can take years for others. But finally, when they do get it, your floodgates will be opened. Now, internally, I'll say that not every paramedic or EMT within your organization will want to be a community paramedic. Now, if you initially ask students that are just starting paramedic school, they'll say they're very far from ever thinking about wanting to be a community paramedic, and they're in it for the adrenaline and the lights and sirens. But as we advance paramedicine in the United States and the opportunities for career ladders, different shifts, different ways of managing our patients, we're seeing more and more buy-in for that.
Gotcha. And another question we have is, if repeat patients are used to being transported to the emergency department every time they call, are you seeing that these patients are a little bit unnerved when an EMS recommends or starts a community paramedicine program, and they offer to treat them at home instead? Is there a level of skepticism involved, among patients, and how do you convince them that they're getting just as equally as great care as they would do in the ED?
So I think initially they're like, well, it's a great question. I think initially they push back saying, well, but the only way to get care is going to the ED. So really sitting down with the patient and saying, I want to hook you up with our community paramedics. They're going to come to your home. They're going to spend time with you. They're going to figure out what's needed. They're going to link you to resources. They're going to get you the medications you need. They're going to help you figure out a way to get into a primary care physician so you can be managed in a non-emergent way. Usually by the end of it, they're so thankful to have another system where they're not sitting in the ED for 8 hours to be seen, and follow-up care, and all in their home. Also, the community paramedics are great at being in the home and identifying other things that are going on that even the primary care can't see in the office. So being able to link those needs back and forth, the patients that I have seen and that I've heard about are very, very grateful.
And this is Chris.
Yes.
One of your examples was a community paramedic who came in who was transporting a diabetic patient routinely to the hospital. And because they were in the house, they were able to identify
yes.
or realize identifiers that forever changed the care for that patient. Can you share that story?
Yes, I would love to. So there was a story where I heard about a patient that never called 911, and then all of a sudden was calling 911 1 or 2 or 3 times a week to be transported to the ED. This is a fully functioning 50-year-old working, and then all of a sudden their diabetes was out of control. So the primary care asked the community paramedic to go into the home and really get down to what was happening. Well, what happened is because their insurance company changed the type of insulin they were going to reimburse for. They had to change to ensure that the medication would be paid for. But the change made an impact on how the diabetes was being managed. So it took the community paramedic going into the home, really sitting down and talking with them to find out what had happened. And that was where the disconnect occurred. It didn't even occur to the primary care because it was just what was up on the list to be checked, to be ordered, because it was on the formulary to be reimbursed. But then the community paramedic took it even further. They went in and with the physician wrote to the insurance company outlining the need, showing how many times they called 911, how many times they were transported, how many missed hours of work they had, and convinced the insurance company to make an exception and allow them to switch back to their original insulin at the same reimbursement. So it goes to kind of show that if they hadn't gone into the home, or if they hadn't taken the time to do that, that who knows what would have happened with that patient. But because of those interventions being so impactful, the patient is now not calling 911 and everything else is on the right track.
Gotcha. And what do you think are some of the biggest misconceptions that patients have about community paramedicine programs, if they have heard of it?
I think the patient's biggest misconception is, first, what is it going to cost? I don't want a big ambulance sitting outside of my house. We have found that when community paramedics come in a large fire truck or an ambulance, the neighbors are worried that there's something else going on with the patient. So a lot of the programs have adjusted with driving a different type of vehicle. And I think just not understanding really what a paramedic can do in the first place. I think they can just treat emergencies. And so being able to sit down with them and help them out kind of soothe some of those concerns and some of those worries.
Gotcha. Thank you for that. And it looks like we have time for just one more question. That question being, have you seen pushback from hospitals about CP programs? For instance, are they upset with decreased patient volume or relieved, or really are they relieved by having less crowded emergency departments? What do you think?
Great question. I'm seeing both. I think at first hospitals were worried that their highest cost center and revenue generator were now decreasing the patient volume. But then they realized some of those patients are the patients slipping through the gaps that may not have insurance or have high deductibles and aren't paying them anyway. And then they're occupying their beds. Then on the flip side, I see hospitals calling up paramedic services saying, I heard about this community paramedic thing. You guys need to start it right away. And the service is like, but first we have to put them through the right education. We can't just start it without doing all these appropriate steps. So I've seen it on both sides. On the flip side, I was just in a hospital 2 weeks ago in rural Montana, and we were implementing Pulsara, and the ED manager said, oh, I'm so excited. Guess what? We're also implementing this community paramedic thing. And I'm like, oh, really? That's awesome. And she said, yeah, we heard about it. So we went to our EMS agency and we're working together to implement this in this rural area. And they're looking, at the ways they can meet those needs. But it was neat to see that being brought up from the hospital's point of view and just even the rural areas.
Gotcha. And thank you so much for addressing that question. So I think that would be a wrap. It doesn't look like we have any more other questions at the moment. And for those who were asking, once again, this presentation is going to be available online later this afternoon. And of course, the 12 steps to developing your community paramedicine program sheet handout is going to be sent to you by the folks at Pulsara that shared their knowledge with us today. Thank you so much for tuning into our webinar, and we will be following up with you shortly with a link to the recording and this awesome handout. Hope you all have a great afternoon, and thank you so much again.